There you go. Okay. All right. So this is our packet. This will be emailed to both of you or to all of you, whoever's here. I think I'm waiting for one more person to join us, and but I'm gonna go ahead. That way we're all on time. Okay. So this is our software, Florida Home Care Specialist at Devero.com. This is web based, and you can use your iPad, your iPhone, any computer, desktop, laptop, um, even like other, not even just iPads, like the other company, Google or whatever. Like as long as there's an internet connection, and as long as you can go to this website, you can access the electronic medical records for Florida Home Care. So the most important thing is, don't save your passwords, because obviously you don't want other people to have access to your user, to avoid HIPAA breach. Okay, so this is the URL. If you get lost, just go back to this orientation packet, and it'll take you, like, step by step on the EMR. So over here on this is the website. On the right side, you see case conference, virtual meeting. So it'll have some information on the right side about updates about the company, things that we need to remind you of, case conference schedules, etc. Okay. So if I'm going to go ahead and connect to Florida Home Care Specialist, show you live. So this is the right side that has all that announcement, and then you log in for your username. This will be given to you by our HR, once you guys are ready, after this orientation. So I keep checking. If you see somebody that's trying to get into this meeting, please let me know. All right, so this is our website, um, for our EMR. On the right corner, you'll see your name, my name, and then resources, and then the three lines. So the three lines would give, you have your access to your profile here. And this is where you could edit your password, your title, your phone number, and your email. And that's all we need is your name, your title, your email, and your phone number. And then click save. Okay. And then to go back to home, you can either click home or click Florida Home Care Specialist. And then it takes you back to this site right here. Under resources, I would like you to review the videos. I think Cecile, I'm not sure if she's given you access to the videos, but this is how you would access the videos. Again, I clicked resources. This opened up for me. And then I'm going to go to training. Under on training, if you're for OT, RN, and PT, you're going to have to review your OASIS part 1 and part 2. Field staff training for everybody. So that's social worker, PTA, OTA, RNs, PTs, OTs, social speech therapist, and home health aide. So you would need to access this field staff training. It's 55-minute video. And this is just going to be an reminder step by step of what we're going to be talking today. So in case you forget, you have this field staff training available for you. The other thing that you're going to review is, we talked about the field staff training, and then go to page 2. We're not hospice, so we're going to skip hospice. So page 3, you'll have your for the RNs and the PTs that's going to start the case, or the OTs, you would need to review the notice of admission creation, the OASIS part 1 and part 2. So even for OTs, you would need to access this one for research, discharges, just a refresher. And then the plan of care module for everybody. So the plan of care module basically creates your plan of care for that patient. Okay. All right. So I have added another person here. Jeanette, can you please introduce yourself? Or Janet, sorry. Not sure if you have a microphone, but we can't hear you. It's okay. I'll just go ahead. So we were talking about, the training modules. Again, I went to resources, click essential training, and then for PT, OT, RNs, speech therapists that could recert the patient, you would also need the recertification process. Page 3, you would need the OASIS part 1 and part 2, which is part 1, part 2 here, and then the plan of care module, and then on page 1 would be the field staff training. So this video is always available for you on the website. Okay, so this is how it looks like for everybody, except of course you'll have different titles up here. So for me, I have my RN. SN would be skilled nursing. For PT, it would show physical therapy or PT, OT, social worker, and then speech therapy. So the packets are used if you're doing an OASIS visit. So OASIS visit would be, when we start the case, when we discharge the case, when we recert the case, or resume cases. So when we start the case, we have 60 days to do to take care of a patient. So you would use the start of care packet. Now, if the patient goes to the hospital, the office will do a transfer OASIS, and then when they come back home and we have an order to resume care, then the RN or the PT or the OT that's assigned to that patient will do an PT, OT, or nursing resumption of care, or speech therapy resumption of care. If that 60 days are not, is not enough for that particular case, let's say maybe this patient is a CVA stroke patient, needs more speech therapy, needs more PT, needs more nursing, you would need to do a recertification packet. You would need to complete this packet. So, but with that being said, we can't just recert a patient, we can't just admit a patient or resume care if we don't have a doctor's order. So everything that we do in home health, we need to have a doctor's order. So if you have like a home health referral that would get you to the door, evaluate your patient, and then after your evaluation, you would have to call the doctor and get orders for your plan of care. So usually, you would talk to the MAs, they're physician extenders, and we're allowed to receive orders from them as physician extenders. So we'll say, hi, this is Michelle from Florida, home care specialist. I just want to let you guys know that I saw Mrs. Smith today, and my recommendation is for her to be seen by nursing twice a week for wound care. I also would recommend occupational therapy to evaluate and treat because of her stroke. And a social worker to help with, Meals on Wheels and community assistance. Is that okay? And then if they say, oh yeah, sure, that's fine, and then just fax us the order, then I would take that as a verbal order. I would take that person's name, and then put it in my order, my physician's order, and I'll show you that in a bit. Then that you also need to get the time and the date of the order that you received, and then obviously your name, your signature, your title would also be on that physician order form. So, and we'll talk about that in a bit. So for before you start your day, you basically have to access my schedule. That way you can see who's on your schedule for the day or for tomorrow or for, for this week. So if you see this patient, I have a test patient here. I'm supposed to be seeing her today at 8 o'clock. And if you hover on this box right here, it would say Oasis Start of Care. It will let you know what type of visit is needed for that particular case or for that particular day. Now, if you have, our week starts on a Sunday and ends on a Saturday. So if you have this on the schedule for a Monday, if it's a start of care, you have to do that on a Monday. But if it was a regular visit, you have Tuesday, Wednesday, Thursday, Friday, Saturday to move that schedule to. So you can just drag, like this one, you can just drag it from any day of that week, as long as, as long as it's on the same week. So I can, if it was scheduled on a Sunday, I can drag it to a Monday, to a Tuesday, to a Wednesday, to a Thursday, or to a Saturday. Now, if Saturday comes and they still refuse care, then that would be like missed visits, like this one. So a unshaded box means that the visit was not done. A shaded box means that somebody has opened the note, whether it's a missed visit or a regular visit note. So a missed visit would be, we missed the visit for patient's reasons. Maybe, they refused care, they refused further visits, or they were not feeling good that day. So that's why we make missed visits on a Saturday or a Friday, like usually towards the end of the day, of the week. Okay, so on this box, again, it'll show you what type of visit it is. It says 34491. They give me like a zip code. That way I can map out my patient. Sometimes it would say start of care. See how on the other patients it says discipline discharge, supervisory visits for LPN. This one says Oasis discharge versus extension. For PT, OT, speech, social worker, it might say eval and treat. And then for nursing, it might say start of care. Usually the nurses do the start of care or the discharges. But, other disciplines can also do discharge except for the social worker. Okay. So now once you know your schedule, you can go ahead and call your patients the evening prior to your visit, preferably before 7 p.m. And then I would go on this patient's particular schedule. That way I know, who's involved in this patient's care. So I know that there's OT, there's PTA, there's an RN, etc. Okay, and then it'll tell you on the schedule, oh, okay, that's a zip code. This is a zip code. Over here, it says supervisory visit. This one says supervisory reassessment. This one says the zip code. This one says the zip code. So if they have particular order, like, oh, it's an INR visit or it's an eval, they would tell you on your box. But, sometimes it doesn't always happen. So that's why we're going over the schedule. That way, you know what needs to be done. So if it says do not move, then please do not move that visit. There's a reason why that visit needs to be done that day. And then over here, it says Oasis discharge versus extension. So anytime that you do a discharge or reassessment, you always reassess if we need to extend or do we need to discharge. So for nursing services, we try not to discharge patients if they still have an open wound or if there's an IV infusion that still needs to be done or a Foley catheter that needs to be taken care of. For physical therapy, maybe there's a recent fall. OT, maybe there's a recent decline in, the upper extremity, what happened, there's probably like a new range of motion exercise or, limitations that the doctor has ordered. So we may have to extend for teaching purposes. But obviously, if the patient's no longer homebound, we have to discharge them. So when they're no longer homebound, meaning they're working, they're up and about, it's not difficult for them to leave home. Those are going to be your non-homebound criteria. So for homebound criteria, they can go to church, to pharmacy, to grocery, to doctor's appointments, to hair appointments, and maybe lunch once in a while, but not like every day to go bingo, every day to go golfing, that those are no longer homebound patients. So that means that we have to discharge them. So even though you have scheduled this patient until July, if they're no longer homebound, well, Medicare or no insurance would be paying you if the patient's no longer homebound. So just make sure that, you're also attentive to the homebound criteria of the patient. So to access this patient, I would go to patient chart. So I can go to the patient chart over here, and then it gives me, information for this patient, the insurance information, their date of birth, their telephone number, their map. I can click map, and that would take me to their home, and then I would just put in my starting address. That way I can map out where I'm going to see this patient. This is their doctor's name, the RN that's admitting the case, or RNs involved, PT, the LPN, the OT, the other RNs, the case manager, the marketer. That way, if you have to coordinate care between disciplines, you have easy access because you have all their emails, their phone number. You can call them, you can text them. But if you text them, please do not text the patient's name, only the medical record number, which is 1027055. So for HIPAA purposes, we don't text patient complete name, just the medical record number. So this is access to your chart. If you need to look at the case conference, it'll give you an idea of what is going on with the patient. This is an institutional referral, meaning the patient is coming from the hospital. And then this is to be filled out by whoever admitted them. So after admissions, after eval, you would have to call us, give us an overview of the patient, what's going on. So the reason for hospitalization was extreme fatigue, generalized weakness, heart failure. And then this is the primary doctor. They didn't give me any information about the vaccines, maybe down here, sorry. So down here, you have more information. Flu, patient has flu, shingles, pneumonia, COVID. This is the patient's allergies. This is the DME, advanced directives, hospital risk, functional limitation, structural impairment, cognitive status. BIMS is part of the cognitive assessment, whether they're forgetful on the OASIS. So I need you to review the OASIS to get the BIM score. And then your frequency, PT frequency, OT frequency, and then nursing. Okay. So you can get to know your patients through your case conference. That way you have an idea of what is going on with the patient. Okay. So to go back, you can go back to the patient chart. It opens up another window for you. You have consent form that's required on admission, emergency management plan, and we'll go over that in a little bit too. Referral, I would also look at the referral, see what's going on with this patient. It gives me an H&P access to, the records from the hospital. So this is a 82-year-old male, coronary artery disease, post-cabbage, heart failure, etc. You have your review of system here, vitals at the hospital, diagnosis, working diagnosis for this patient. And a lot of the times you have the medication here, but I don't go by what they are taking at the hospital. I usually go by their discharge paper from the hospital. So when I see my patients, if I'm doing the admission, I always ask for their discharge papers from the hospital. I assess what medication they should be on and what medications they have available at home. That way, if there's any discrepancies, I can call the doctor and help the patient out, help the patient figure out what medication they need to be on. Okay, so that's your H&P there. Physician orders, also check them. That way you're not missing anything, whether we're doing blood work, are we doing wound care. So it just has home health with concierge, PT, and OT for Mr. Berger on discharge. So they didn't send this patient to concierge. Instead, they sent this patient to us. And then their electronic signature. So it says home care, PT, OT. Okay, so that's your order there. And then this is your Oasis that she did, and then these are some attachments that we have to do when we do a start of care. You also have access to nursing notes, PT notes, OT notes over here if they're available. So it's real time documentation. If you have typed in something for the patient, everybody could see that. I could see what OT is doing, I could see what nursing is doing. I cannot edit it because I'm a nurse. I couldn't edit anybody else's note. Even my other nursing notes that are done by other people, I can view them, but I cannot edit them. Okay. The med profile, if you see anything that's pending, that means that those are editable, that stays pending until the patient gets discharged. That way everybody could add on to any medication. So this is just your medication example. Okay. And then if you need to add on anything, then you just click add. However medications you need to add. Let's say let's add lisinopril. So it takes you just have to type in the first 3 words or 4 words or whatever, and then 1 tab. You always complete your sentence, 1 tab daily, twice a day, or whatever. All right. So, and you also have to ask the patient, how long have you been on this lisinopril? Say, for example, this is an admission. How long have you been on this medication? Because if I put that this patient is new to all these medication, that means that I'm supposed to be educating them on all of this. But I'm assuming, some of these medications are long-standing medication. Okay, I'm gonna delete that because this is not accurate for this patient. Okay, and then always review this with your patient and your caregiver, and then always check that off. And then the date of the drug regimen review, which is usually your admission date or when there's any changes on your medication. And then click sign and save that form. It's going to ask you for your username and password, and then click authorize, and that becomes your electronic signature there. Okay. All right. So any questions so far? Okay. So where are we? All right. So that's our that's our um that's our access right now. The medication we talked about. Okay. So let's go back to here. Again, what I did here was I went to the patient, I clicked the patient chart to have access to that chart. But I can also go home. If you ever get lost, you can also go home, click your patient here, test patient, and then you can click patient chart to open that patient's, so you have access to that patient chart. All right. And then the packets here, again, it's available for you. The packets are already arranged based on the requirement for a start of care. So for example, if you're doing a start of care, you have the Oasis that's required, the medication, admission, ongoing advanced care plan, emergency management plan, and then the notice of admission. Those are all the requirements. For PT, OT, speech, social worker, eval, you would just click on an eval form, and that's all you need. So for the nurses and the PTs that are starting the case, it's more in depth. But for the clinicians that are just doing the evaluation, you would just have to complete an eval form. But
And
for
where do
OT,
you go to look for the eval form? Where does it show up?
so it would be under packets, and then you would see like PT eval or OT eval or social worker eval. Okay. And then you could also find it under clinical forms or the packets. I don't have a social worker view because I don't have access to you guys's user. But for you, as a social worker, the only, I think the packet that you would have available would be the eval packet and a discharge packet. So you would probably have 2 or 3 here under packets. Okay, and then we'll look for like a social worker form in a little bit too. just to give you an overview. Okay, and then you scroll all the way down. This is how you start a note. So you click on the patient, whether you're doing a start or a regular visit or an eval. So an eval would look like like a psychiatric eval, which we usually we don't do because we don't have any psych nurse, but it would say here like a MSW eval or PT eval or an OT eval. So you would have to click on that eval, and then it opens up other forms that are available on that packet. So if you're going for the packets, then you would see multiple notes that are required or possibly required for that. But if it's just an eval, you would just click an eval form. Okay. Oasis forms, you don't need to access this Oasis forms because this is already part of your packet. Clinical forms, you would have social worker visit, PT visit, OT visit, nursing visit. So that would be here. So if you need to open a note for this test patient, I could click on this skilled nursing visit note. It would ask me for the visit date and then what type of billing code I need to do or use for this patient, and then click create. So I don't have a valid frequency, but if I do have a valid frequency, then it would open up a note for me. Let me try to get a Berger. So let me go to Berger. So if I'm going to do a visit note for this patient, and then this was scheduled for last week, and I'm going to go create, it's going to open up this note for me. So for other disciplines, it would say PT visit note, OT visit note, social worker visit note. And then you would put in your mileage. Usually the first patient is 0. And then the time in and time out is also required. So you have to have at least like a 30-minute, visit time for a regular visit. That's your minimum. For everybody, PTOT, speech, nursing, home health aid, you need to have vital signs. But for the social worker, they don't require you to do vital signs on your note. Additional requirements here would be the blood sugar for all your diabetics. So whether you're a PT, OT, or a speech, you need to have a blood sugar level. You don't need to do it yourself. You just have to ask the patient whether, what's their blood sugar, or, whether it's fasting or random. Pain assessment, skin assessment would be here. For physical therapy and occupational therapy, you would see like more functional visit note. This is more of like a head to toe assessment for nursing. And then if you see anything that's grayed out, that means this is part of your plan of care, and all you have to do to document that visit for the day would be just to insert and choose whatever is applicable for that plan of care. All right, and then click insert to form. So for physical therapy, you would see if I was a physical therapist, I would still have the same view, but then I would click on like a different intervention, since I don't do medications. As a therapist, I don't do like maybe other wound care or anything but my physical therapy treatment plan, and then click insert to form. So that goes there. You don't have to type in your narrative. What you're required here would be maybe like, like how patient responded. So maybe patient was very forgetful, patient very tired during exercise program, unable to perform whatever activity that they were not able to perform, and then patient took pain pill because they were in a lot of pain, etc. And then goals here, you would click under goals. You would insert whatever is applicable, what goals you've worked on for this patient. And then over here, status, if you've met that goal, you have to put the discontinued date here. And then if you've not met this goal, maybe it was just like a 30%. Maybe I would say patient very forgetful and tired during the visit, unable to retain information given. That way there's an update of what's going on. Hey, why are we not meeting that goal? What's wrong? What's with this specific goal? Patient would be able to walk independently without fatigue. So I would say, oh, this one was really just 10%. Patient was really tired due to lack of sleep evening prior. So whatever is whatever is going on that goal, just give us a quick update of what's going on. So on each note you would have to at least address 3-4 goals. You don't have to finish the whole thing. Just be mindful of your frequency, because if your frequency is for this goal to be met in 2 weeks, you need to work on those goals to be met in 2 weeks. Supervisory visits, if you're an OT or PT that's supervising a quota, or a PTA, that's also available here. And then if you're an RN supervising an LPN or an HHA, you would also have to access this one. Ask these questions here from the patient. If you coordinated care between disciplines like physician, the case manager, the PT, and whatever, the nursing, I would say, change in care plan, patient fell, went to ER or whatever, vital signs was abnormal, call the doctor, to report. That would be coordination of care. And then discharge planning, always do a discharge planning on each visit. We're not keeping patients forever, so make sure that your discharge planning on each visit. Mrs. Smith, I have 2 weeks left, 3 weeks left, we're going to be discharged you if you're no longer homebound, etc. And then over here, click to sign. So the patient signs this note, then either accept. If they say, oh, I don't like my handwriting, let's clear that, so that clears it. Once you accept the signature, then there's no turning back. All right. Also be mindful that when the patient signs this note, that this has electronic verification of visit, meaning this software also has access to where this document was signed and the time and the date of the signature. So we need to make sure that this is to prevent fraud cases with home health, because there were a lot of issues with home health fraud in Florida. So that's why they have made all these new rules and regulations, because of the fraud that was going on in particularly in the state of Florida, Illinois, I think California. So those are just some of the few states that were under the radar. So again, make sure that you sign and we're being truthful on the signature, because it gets tracked. So, and then once you accept the signature, see how it's saved at 9:37 a.m. And then once you click sign and save, that becomes your signature as well, and click authorize, and it's going to boot me out of this system. But don't worry, because you would still have access to that. You would just have to go under pending in the bottom. So you have the to be corrected. So your goal is not to have anything under to be corrected, nothing under to be signed, and then nothing under pending. So I still have my Mr. Berger here. So if I open this one, you will see that my signature is here, timestamp, and then the patient's signature is on the second page, and it's also timestamp and then dated with a time, and then that's their signature. This visit didn't really happen, so I just want to make sure I'm going to delete it. Let me just delete it. So for you guys, if you made a note by mistake, just call us at the office and we can delete it for you. So I'm just gonna go ahead and delete this. Okay. So on Burger, let me see if I can delete it here. Nope, I can't. Okay. So anyhow, so that's the note. That's how you would do like a regular visit note. Now I'm gonna give you just a quick overview on a start of care test patient. So the start of care packet looks like this, and again you have all these requirements here and the NOAA. Make sure that you are working on the correct episode, correct date. If it's a research packet, it would look like this, and these are your requirements: nursing oasis research, admission ongoing care plan, med profile update, and then the Braden scale. Eventually, this Braden scale is going to be embedded on the research, but we'll let you know once that's done. Resumption of care looks like this. So you see how, like, you have lesser requirements on a rock and a research compared to a start of care. So you have your resumption of care, your advanced ongoing care plan, and your medication profile. The Cornell scale for depression is just available for you in case your patients are not verbally responsive. They're not alert oriented, that they cannot answer your PHQ-2 or PHQ-9 questions. So you would need to do Cornell scale of depression if they cannot answer verbally or they're not reliable. And then a discharge packet looks like this. So discharge meaning you're discharging this patient from the entire agency, from nursing, from PT, from OT, speech, etc. If you were just discharging them from your discipline, then you would do a discipline discharge. And then if you were discharging them from the whole agency, then you would use the OASIS discharge. Okay. So I'm going to go ahead and look for a social worker eval. Don't be confused with this user. This is my admin user, so I don't want you to pretend you're not looking on this one. I'm just really looking for a social worker eval. Okay, so this is an evaluation form for social worker. You would have your name, and then the billing code. So it's just either a courtesy or MSW visit. So obviously you want to be paid for it. So you want to do MSW visit, the date today, the travel time, mileage, time in, time out, diagnoses, prior level of ADLs, pertinent medical information, psychosocial, current living situations. It's more of social questions versus, head to toe assessment. And then again, because it's an eval, there's like more pages involved. So you have, significant others, more social determinants, more social questions. Patient received care at home, patient's present situation, identified problems. So it's more of like social issues versus physical. And then this is where you would put your intervention. So you would click insert from template, and then category, you would go under social worker, treatment plan, and then you just click and choose whatever is applicable for your patient. So I'm not going to choose because this is somebody else's note. I don't want to do something and jeopardize them. I can access this as an admin, but as a nurse or as another social worker, you can't access this and edit. And then care planning coordination, yes, you want to always call the case manager to give a report. So for all evaluators, you really need to call us for a report and then do a discharge planning at all times. And then again, you would click sign and save this form if you were the therapist or the social worker that was seeing this patient. And then the patient, I believe, signs in the front page. So this is where their signature is at 2:27 p.m. Okay, so timestamp. Now I'm going to be looking for OT.
I had a quick question about the MSW.
Mm-hmm.
So typically, most of the evals is a one visit event. So do we do a discharge process for MSW when it's just a one-time visit?
So you would do a discharge planning as well, and you would just say that you're only here for just one visit, and because you're evaluating and discharging them at the same time. So
Right.
so basically you would just have to say, this is just a one-time visit, and then on your discharge planning, it's basically like a jargon that just says,
What's going to happen? Yeah.
Yes. So for MS discharge, we may transfer you or discharge you when the organization or the physician agrees that the transfer or discharge is necessary, or we transfer you or discharge you when you go to the hospital. So that's just the basic lingo for discharge. It doesn't really necessarily mean that, oh, we're discharging you if your meals and wheels are like will get here or something. So this is just like criteria for discharge for the patient. Like, if they go to the
Hmm.
hospital, they don't come back, we discharge them. If they're no longer homebound, we discharge them. If they
Right.
don't follow the if they're non-compliant, we can also discharge them. Okay. But if you want to be specific, you also can do that by clicking on add new row. And I would say, discharge patient once, discharge patient with maybe like DCF. If you call DCF, then I would say DCF supervision, whatever. So if you had other community involved and then you want to document that, you can also click add new row and then type in whatever discharge planning you've made for that patient. Okay. Is that clear? Did I answer your question?
Oh, I'm sorry. I'm responding and I didn't realize I put mute. Yes, yes. Thank you so much. That's clear.
Okay. So, all right. So let's go home and then I'm going to go look for an OT. Um, OT, select form, OT, occupation. So eval, I'm gonna occupational therapy reassessment and the visit note. And then I'm also just gonna show you physical therapy. That way you know what it looks like. Physical. Okay. So again, don't be confused with this view. This is for admin view only. For OT eval, this looks like this. You have your travel time, mileage, time in, time out. OT eval, we don't do telehealth. We had that available during the pandemic, but no insurance would cover that anymore. And then patient history, subjective, you have your vitals here. You also have your blood sugar right here for all diabetics. Um, Scales that you used, blood sugar is here or here, it doesn't matter. Sensory pain, you have your skin assessment, just very simple skin assessment, not the in-depth like the nurses. Okay, so you can either click on the pages here or click save in the bottom and it takes you to the next page. And then you also need to assess mental, psychosocial, cognitive, musculoskeletal, because I think it's also part, like there's like an overlapping sometimes between PT and OT, so we have to be careful with that as well. ADLs and IADLs assessment here, activities permitted. So anytime that you see, oops, okay. So assessment summary, she type in over here. So anytime you see a red icon, that's part of the care plan. So you're gonna have to click, oh, that's eligibility, that's my plan, this is my skilled services requirements, I'm an OT. So yeah, the CVA would be applicable for me, the weakness would be applicable for me as OT, the debility, maybe the aphasia more with speech therapy. I still have to do my homebound part 1, part 2. So whatever the nurse has, like usually the nurse or the PT, whoever started the case, would develop the homebound criteria, and then you just follow through. If you have a new information for that patient, you can always click add. Okay. But if you want to keep it simple, you can just insert what the previous clinicians have, entered. And then intervention education provided, she has that there. And then supervisory visit, and this is your plan of care. Your frequency needs to be put in here. If you were a social worker, you would put here. Nursing would put here on the section. Rehab potential. Again, you have to click that one, insert from template, and choose whatever is applicable for you. So this is part of the care plan, because remember, this is your eval. And then you would have to set goals for this patient. You would have to set interventions for this patient. And then this is their occupational therapy assessment. We still have to assess coronavirus because it's still, very infectious. And then discharge planning here. And then your patient signature, and then click sign and save that form once you're done. Once you're done and ready to send it to the office, you would have access to send it to the office. So I'm just gonna show you real quick how to send it to the office. So say, for example, you're done with this assessment, you would just click send to office. And again, it's going to ask you for your username and password, and then click authorize, and then it gets sent to the office with additional signature time and timestamp and date for you. So this is for nursing visit. We talked about the OT eval and the social worker eval. PT visit would look like this. This is the physical therapy visit note. So the OT visit note is also kind of similar. Just one page for you guys. For nurses, there's 2 pages. So it's kind of like basically almost the same. I'm looking for an OT note. Right here. So 1 page, vitals, pain, eligibility, intervention, and if you need to do a soup visit, you can do that here. And then discharge planning, click sign here, and then send to office if you're ready. Okay. So for orders, if you need to do an order for a patient, sorry. So let's go on test patient. That way I can play with this patient. So if I'm doing an order because I need to extend, I'm going to have to go under, clinical forms. And then maybe I'm doing a physician order frequency because I need to extend the frequency. I called the doctor today. Okay. And then my doctor is maybe Dr. Villacastin. And then I'm going to say, you're going to have to answer these questions here because that way it's going to help you. Who, what, where, when, why. So I'm just writing this just to, give you at least like a scenario of what to put here. So SN, what, extend, nursing, services, where, at home, obviously, but when, usually probably not where, but when would be effective date, effective 06/09/23, and then my why would be, my where would be probably like work on the lower extremity, or why would be to perform wound care on left lower leg as follows, and then using aseptic technique, cleanse wound with blah 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 blah. So if you were a PT or OT, you would probably put PT or OT to extend therapy, PT services, effective this date, why, due to recent fall and debility, goals were not met as patient patient needs to ambulate with device and standby assist. So That way you're justifying why you need to extend your frequency. So once that's done, you can just delete the who, what, where, when, why. OT to extend PT services effective this date. Why? Due to recent fall. And then this is your frequency, twice a week for 4 weeks or twice a week for 5 weeks, effective June 9. So then that's a complete order. And then the order received by whoever you are. So I'm Michelle Rothlow, RN. That's important. The date today. I called the doctor. I spoke with Christine, the MA, and then Dr. Villacastin. And I just spoke to her just a minute ago. So I would say 9:43 or 9:45. And then this effective date is June 9. And then verbal order, read back, and then sign and save this form. Okay. So if you notice, oh, sorry. I didn't do anything on the lower section. I stopped at verbal order. So all your communication needs to go here. All your orders need to go here. This bottom section is for clinical managers at the office. So don't touch this part, only this part right here. And you end until verbal read back and verified, and then the effective date. Okay. Once you're done with this order, you click send to office, and then that, you would have to sign and save, and then click authorize, and that gets sent to the office.
I have a
Okay.
quick question
Yes.
in terms of for the social worker, where I've had patients who say, "Oh, is there any way I can get a seated walker, or I need a cane, or
Mhm.
a bath seat, or the handles, bars?" Is that something that I would fill out that form, or would I speak to, the nurse or to put in that order?
I would have to ask you to call the doctor if the patient needs it. We don't get involved with the DME because we always get in trouble when we when we try to be in the middle between the DME and the doctor. Because what's been happening is the DMEs require a face to face. So that means that the patient needs to be seen by the doctor needs to certify that the patient needs a cane or a walker and why. And then the doctor's office would need to submit that documentation to the DME provider. The DME provider would have to either check and verify if insurance covers this. And then if it's a go, they would order it, send it to the patient. But if we are in the middle, the patient would think that we did not do our part, but in reality, it's really between the doctor and the DME provider.
Okay, but I would enter that information in the body of my note indicating, um,
Correct. You would put
patient.
that under coordination of care.
Okay.
Okay, and then I would say coordination of care spoke to Christine at Dr. XYZ about the patient's need of a cane or a walker. They've scheduled the patient for a face-to-face on blah blah blah. That way, you did your part. You did what you could for that patient, because in reality, we do not order that for the patient. We facilitate, we help, but just let the patient know that the DMEs are between the DME company and the doctor, because we don't. So some agencies, they are home health and a DME provider, but we're just solely a home health provider and we don't do DME part.
Okay, thank you.
Uh-huh. Okay, so any questions for others that are here, OT and nursing? So if none, again, I'm just going to go under resources. And under resources, this opens up for you. You would go under training. These are tutorials and interactive training. You would need to do your field staff training on page 1, field staff training. And then on page 3, you have your OASIS part 1 and part 2, and then plan of care module. Sorry. And then you just have to click play, and then it's gonna give you like a video and what the oasis looks like, and explain to you what the oasis means, what questions need to be answered, how to skip them. So that would be like your oasis review. Okay. And then over here, this is our orientation packet. Again, this will be emailed to you. Oh, I can't. Hang on. Hmm. Okay. So for clinicians that admit the case, these are some of the requirements for start of care. You have your consent here. Always start with the consent because I'm sorry. So always start with the consent because you don't want to waste your 30 minutes with the patient only to find out that they don't want home health. Make sure you have your frequencies here. You don't make for, like, if I was a nurse, obviously I'm a nurse. If I'm the nurse admitting this patient, I would only put my frequency. And then if I recommended PT, OT, and social worker, then I would put eval. But then if the patient refused the eval, then you would just click refused here. I mean, type in, and then their initials for payment, that they are aware that we only go there for authorized visits, and if they are not authorized by the insurance, then this is how much it would cost, but we will let them know if they're not authorized by the insurance. Obviously, Medicare pays 100% for insurance, for home health. And then we always ask for advance directives. You fill that out, the patient's signature, the date, my signature, the date. If they are not able to um, sign it, you have to put the responsible or the legal guardian, and then the relationship and why are they not able to sign. And then acknowledgement of receipt, that we have to talk about bill of rights, transfer discharge policies. Again, we talked about the transfer earlier, or discharge. And then the bill of rights, they have the right to say yes to treatment, say no to treatment, the right to be informed of when you're going. That's why we call them the evening prior to the visit. The right to be notified if there's a change in their care plan. We also have special instructions that we give them in writing. Complaint process, CHAP hotline, and ACA are also on your admission packet. Once you go out for your field orientation, you would also see this packet. Or when you go to the office, there's also like a green packet in the office that you could review. And then the calendar of visits also, this would be part of the field orientation. And then patient representative, who can we speak about the case and who can we not speak about the case, and the phone numbers and how are they related to the patient. If they have someone that they don't want us to talk to, this is where they would put it. And then their relationship, that way you're not violating any HIPAA. If XYZ calls and they don't want to talk to XYZ, then we have to be mindful of that. And then patient signature, your signature, and then your title, and then the date. Patient instructions, so this is also part of your admission packet, the green folder. No abbreviation on any of our documentation that's given to the patient or to the EMR. Leave dressing until March 3rd or January 3rd. So if you notice, we write legibly and we don't abbreviate because we have to make sure that the patient understands the instruction. No bending, no lifting, no twisting, chest pain, call when temperature. So you have to be as specific as you can. And then this is an example of a paper med profile instruction that we give to the patient. So the med profile, it's duplicate. Unfortunately, we have to give them paper, and we have to do the electronic part as well for our care plan that we send to the doctor. And then we have to give this paper form to the patient. So whatever you wrote on your EMR, that also needs to be written on the paper to give to the patient. And then some medication instructions. And then these are the type of requirements. So SOC is start of care, ROC is resumption of care, and these are the requirements. You scan it, it's paper, it's scanned, and it's attached to chart. Patient instruction is paper, scan, attached to chart. Acknowledgement form, the same. EMR required, you have your OASIS and then the medication. And then the medication, it says EMR, leave a copy for patient, take a photo of the copy left for patient, and attach the photo on med profile section of the chart. And then other requirements are emergency management plan, advanced directives, and the notice of admission. All right. And then research, other follow-up is when the patient has declined or there's a significant decline in the patient's condition, then you do the other follow-up. And then OASIS discharge. Discipline discharge is when you're discharging the patient from your discipline. And then after your admission or evals, you always report to the care management. Clinical managers to review case and fill out information. The referral for this is a referral from the hospital, patient admitted to the hospital for whatever, any procedures, what's the focus of care, what's the allergy. This information is also going to be posted on your case conference. So that earlier we looked at the case conference. This is basically what you're going to report to the clinical person that you're talking to. And then structural impairment, functional limitation, activity limitation. So be specific. So structural would be what is wrong with the patient's structure. Do we have a wound? Do we have an ostomy? Do we have scoliosis, deformity due to RA, things like that. Functional would be pain, incontinence, gait instability. And then activity limitation would be no bending, load lifting, no twisting, as an example. And then wound assessment, mental status, and then your frequency. And then the plan of care requirement is when you make your care plan, which is on the OASIS, and you're also going to have that overview on the OASIS. And then this is usually on the last page of the OASIS or the last page of your eval. So this is going to be all, earlier we talked about the eligibility, the face-to-face, the part 1, part 2, part 3. So it's easier for the succeeding clinicians because the one that usually determines the eligibility is the admitting clinician. So they do the hard work, and then the PTOT or social worker would just follow through. And if you need to add something, then you can add something. And then interventions that are required for admission. And then if you're a PT, then you would just do PT treatment plan that you did an eval, or social worker treatment plan. And then the goals. So whatever you put in your interventions, you also have to have goals for them. And then the discharge planning. Clinical expectations. Please submit your notes within 48 to 72 hours. Attend case conferences. Coordinate care. Notify our company if you are calling in sick at least three hours prior to your time in. Call report as soon as possible, after eval, after admission. And then follow physician protocol. Do not express inappropriate comments about other clinicians. For example, they're not happy how therapy exercise was not done but this way and this was done that way. Or how wound care was done differently by another nurse. We don't talk about other people. We just ask for, if they have concerns, then we have to put it as a complaint, and then, listen to the patient, but don't make inappropriate comments about other professionals and doctors. So if the doctor didn't do it right, then just say, you know what, I have to verify this, but we don't bash each other. We don't talk bad, especially, maybe they have a reason why they did what they did. But we cannot assume that they're wrong just because the patient said so. So we don't usually talk bad about other people. We don't call them honey or love. Wear closed-toed shoes at all times. Wear scrubs. If you don't wear scrubs, then at least make sure you have your badge and a professional attire. So not gym clothes, cycling shorts, or anything like that. If you're a lot of our therapists, they wear street clothes and then they wear white jackets. That's acceptable. For social worker, you can use your professional clothes and make sure you have your ID badge. And then
Are we getting a badge from the company?
yeah, you should. Yes. And then coordinate care. What else? These are just some examples of education that we give to the patient for nurses, for example. Like your congestive heart failure, make sure that they have a weighing scale, that they're weighing themselves, diabetes, are they doing their checks? Hypertension, do they check their blood pressure, things like that. Clinical clinical conditions of participation of care, these are required by the government. So just make sure that we're doing this. We're doing medication instructions, we're putting in their calendar, we're notifying them when we're going. Any change in the order or frequency, that the patient consent for the change, that they're aware of the change. Did the patient receive all care stated on the plan of care? Because if you said that you're going to assess for diabetes, then you have to have at least glucose check, teaching on diabetic foot care. If you said that they're going to refer them to Meals on Wheels or community resources to help them with food, that's documented on your note. Patients' rights, transfer discharge policies, notice of complaint process, so they can lodge complaints to our company, to our administrator. We don't retaliate if they're not happy with our services. Let's find out why, and then maybe help them. If we cannot help them, then we may have to refer them to another agency, but we just don't drop them just because they said something bad to us or bad about us. Missed visits, please make sure that this missed visit was done based on their reason and not based on ours. So I can't make a missed visit just because I have a dental appointment. So it has to be patient not feeling well today, or patient went to see their doctor, could not come in on time, or refuses to be seen today because they have family that's coming over, something like that. And then missed visits, you need to text the scheduler right away that you've missed the visit. That way we can either find someone or move it to another person's schedule. And then physician order, we talked about. These are just some examples. Recertification order, you always have to make sure that you put how many days are you going to be recerting this patient for. So if you say PT to extend care and recertify patient for either another 60 days, another 50 days, another 40 days. And then homebound reason examples are here. ALF and ILF protocols are here. So ILF and ALF, wear your badge at all times. You report to the nurse on duty, get the nurse's name, document it on your coordination of details. That way, if they question who you spoke to, we can tell them that, oh, I spoke with Nurse Jeanette or the tech Jeanette or whoever. And then CHAP refresher, make sure that we have a clean side of the trunk, clean side of the car, dirty side of the car, or clean side of the bag, dirty side of the bag. Bag technique is very important for infection control. Hand washing procedure, it is now acceptable to do sanitizer. So if you don't have a house that has good water supply, or you feel dirty, some patients' houses can be dirty. So if you don't feel like hand washing at their bathroom, then just do your sanitizer. You can use your sanitizer. And then that's infection control, COVID protocol. I'm sure everybody's aware. Ask your patients the evening prior, do you have any history of are you sick? Are you okay with me coming out to see you? Any coughing, feeling under the weather, any fever, etc. So you still have to do your assessment. That way you can protect yourself. Because if they're having respiratory symptoms, they have fever, not feeling good, etc., we don't know whether they're COVID or flu or whatnot. And if we have N95 available at the office, that way you can also protect yourself. We don't require masks anymore, but it is optional. So if you still want to use mask, if you still want to use N95, you can drop by the office and pick some supplies at the office. Interdisciplinary notes will be discussed during your field orientation. It would be good for you guys to see like an example of the packet. That way you know where it's at exactly on the admission packet. But your interdisciplinary note doesn't need to be in depth. Usually I just put vitals, wound care done today, or vitals and then PT visit regular PT exercises done today. Signature log is another piece of paper that is handy if you have no internet connection at the patient's house. So if you're not able to get their patient signature, then use the paper log. Company protocol: call for report as soon as possible. Oasis visits and notes are to be submitted accordingly on time. Call the patients the evening prior to the visit, prior to 7 p.m. Your issues are never the patient's issues. Do not email, text any patient confidential information. Only either the four letters of their name, but it's easier for the MR number. Research: we need orders. We need to discuss it with the case manager. And then some physical therapy guidance and occupational therapy guidance are also here. Guidelines for therapeutic procedures, just some examples for you guys for the therapy. Parameters: these are your parameters for your vitals. It's also part of your care plan, so if it's outside your parameter and you need to call the doctor, that better happen. That the doctor needs to be informed if the blood pressure is greater than 170, or the blood pressure is less than 100/50, and the patient is having some lightheadedness, dizziness, orthostatic hypotension or whatnot. And then interventions: make sure that they took their pills before, either before that you took that blood pressure medication. Assess them if they're in pain. Assess if they have any PRN medication if their blood pressure is high. So don't just call the doctor right away just because you have a high reading. Make sure you also do your intervention. Did they take their pills? Do you need to give them their pills? And so on. All right. This is just home health change care of notice, and this is just an example of how to fill this out. This is done whenever the doctor says, say for example, your care plan was to see this patient twice a week for 5 weeks, and then on the second week, the doctor says, oops, discharge PT on second week, because I need to hold off with exercises because the patient does not have to be on weight bearing, blah, blah, blah. So then it would say stop or hold PT, and then the reason for change, the doctor has changed the order. So this is again part of their patient rights, that they have to be informed and they have to consent of that change. Advanced beneficiary notice is when Medicare does not pay. So for example, they want you to continue doing wound care, but it's just a band-aid. So a band-aid can be done by kids 8 and above. So if kids can do it, I'm sure this older adult could do it. It's not a skill by a nurse, because so when you talk about a skill, it has to be a complex wound care. So a band-aid won't be considered complex. Medicare won't pay for a band-aid visit. So you would say, oh, nursing visit, wound care supplies will not be paid. And the reason, because this is no longer a skill and this is how much it cost Mrs. Smith. So if you agree to that, then I may have to collect check payable to Florida Home Care, because we know that the insurance won't cover for it. Or they could say, oh, you know what, don't do it. I'm okay with the discharge. Then you would do a notice of Medicare non-coverage. But if they say, yes, I want you to do it, I want you to bill Medicare, and if Medicare denies, I will pay you. So this is basically like an advanced beneficiary notice of non-coverage. You're telling them that this is not covered by your insurance because it's not a skill, or maybe they're no longer homebound. And then lastly, this is notice of Medicare non-coverage. This needs to be done at least 2 days prior to patient discharge. So this is a requirement before any discharge could happen. So if this was forgotten, say for example, today was your discharge date, I would date that the patient signed it today, but then my end date here would be 2 days from today, meaning I'm still giving them 2 days to I'm sorry, I'm still giving them 2 days to appeal to Medicare or to their insurance that they're not agreeable to our discharge decision. So this form is required to give patient a written notice that we're going to be discharging them. But if it did not happen on the day of discharge, you can still give them 2 days to appeal to this insurance. if they're not happy with your decision to discharge. So this is what that form is. So don't freak out if it wasn't done. Again, you can put the end date as 2 days from your discharge date. That this means that you're giving them 2 days to appeal to that insurance about that discharge decision. Okay. Any questions?
If I go see a patient that needs more visits than one visit, because just to get them connected and or depending on the case, um, first we have to get approval from the insurance
Mm-hmm.
to see if they'll pay. So in
Mm-hmm.
that case, do I document that, and then like how does that process work?
So if on your eval, instead of, remember that frequency on the eval form on, I think on the last page, on that eval, instead of putting eval only, then you can put once a week for 2 weeks, or once a week for 3 weeks, or whatever. And then you can just say pending approval from insurance. You can say that. And then when you call the doctor, just say, Doc, I evaluated this patient. This is my plan, is to see this patient once a week for 3 weeks, but we're pending for authorization from the insurance. And
Okay.
then if we get that approval, then we can always schedule that frequency. If we don't get the approval, just ask the patient, are you agreeable to me seeing you again 1 or 2 more times, but it's going to be out of pocket?
Mm.
Okay. So
And
sometimes it's difficult because some patients really, that's probably why they need a social worker, because they couldn't afford. So if
right,
there's any blockage from the insurance, usually the insurance will give us maybe 2 visits more, but I'm not sure for more than 3. I don't know.
right. And that's fine. It's just that I find that a lot of patients need more than just a one
Right. As long
visit.
as the patient agrees to pay out of pocket, then yeah, that's fine. But if they won't, it's really up to you and the clinical manager on how to deal with the follow-up. So whether maybe, I would say, if it was an abuse and a neglect case, then even if it's not covered by the insurance, maybe the clinical manager and you could talk and say, hey, why don't we meet halfway and do a telephone call, and we'll pay you for admin time or something like that. But if it's not an abuse or a neglect case, and it's a community resource, and you gave the patient like the information that you could have, then maybe like the nurse that's following the case would probably help follow up with, hey, what's going on with the community resources? Did you call them, etc.
Okay. Okay. All right.
Okay. But if it was like, let's say, a frequency of 1 week, 2 for social worker, and then you say, oh, I really just need that one more visit, you know try to get authorization. We'll get a doctor's order. You have to write your own doctor's order, like I showed you earlier, physician order, etc. MSW 1 week 1, effective this date, to follow up on Meals on Wheels patient reports not eating for a day now due to inability to afford meals, or not able to get their own meals, or whatever. And then if the doctor approves it, the insurance approves it, we'll schedule you. But we still have to have a doctor's order if it's not part of your initial eval.
Okay. Thank you.
Mm-hmm. Okay. Any other questions? Erica and Janet, any questions?
Nope.